webinar is to give you an update on the progress that's been made to date within the cluster, and to give you a sense of the projects that are being funded in phase 1, and then some of the next steps that are planned. So that the voices that you'll hear today is myself, Mark Harrison, who is joining to give a description of a project that he's a co-lead on, and then Stephanie Harvard for one of the other projects that are part of phase 1. Nick Bansback is my sort of co-lead with the methods cluster, but Nick is now part of today's webinar. So what we're just looking to do today is explain some of the progress that we've made since the summer and fall of 2017, quick explanation of the amount of stakeholder engagement that we've had, and give you a sense of the projects that are moving forward in this first round of projects. Towards the end, we're happy to take questions, and we would like your input into the whole process. I mean, one of the key issues for all of the methods clusters is to get input from stakeholders as often as possible. And as I said, there'll be some information about the next steps for this particular cluster. So this slide just gives you a summary of the different types of stakeholder engagement that we've gone through over the past 12 months or so. And this has involved one-on-one conversations with researchers across the province who we initially sort of targeted, who we thought would be interested in this initiative. And then around sort of the late spring and early summer of 2017, we conducted a survey that included an expression of interest for people to indicate that their level of interest about attending a planning event later in the fall of 2017. And at that planning event, we had around sort of 35, 36 attendees, and we really sort of, it was similar to like the launch of the methods cluster. So it was explaining the links between patient-oriented research and health economics, some exposure to the type of projects that could explore, and really telling people about the objectives of the methods cluster and the fact that we were looking to fund methods-focused health economics projects. For people that couldn't attend the planning event in person, there was a webinar that was conducted a couple of weeks afterwards, and that webinar is available on the support unit website. And then throughout all of these consultations, we gathered feedback, and that helped us devise themes and project areas that we could move forward with in for the duration of the methods cluster's work. And this is just a screenshot from the support unit website, and it shows some of the resources that are available on there. So we do have a report on stakeholder consultations, so that the events that I've just sort of described to you are explained in more detail in the stakeholder consultation report. And there's also a link to the webinar that was conducted after the planning event. So for those of you who may be interested and didn't attend that planning event, then all the information can be accessed through the summary webinar link on the support unit website. So in gathering all the information and the feedback that we got from the different initiatives that we've been through, Nick and I came up with these 8 themes. And the intention isn't necessarily to try and fund one project per theme. This was more an idea to get a sense of the breadth of work that we could be interested in funding, and really ensure that regardless of the research area that you worked in health economics or simulation modeling, then you would have a home within, a potential home within the themes that we could look to fund. So it's highly likely that no matter what the project area is, then you would find a fit within the themes that we came up with based on the information we got from different stakeholders. In terms of how this all came together, much of the stakeholder consultation was over the summer and fall of 2017. And then once we gathered that feedback together and established the themes and began to talk to people about potential projects, that was towards the end of last year. So the refinement of those projects and putting together an initial work plan and finalizing that stakeholder report happened in early 2018. And the initial plan, as you see in this timeline, was for external review and the commencement of projects to be around April of 2018. That timeline has been sort of slightly pushed back. The projects are currently under external review, and it's likely that those projects will will commence probably in July, maybe into August of this year. So at this point, I'm going to hand over to Mark Harrison to say some words about the project that Mark is leading. So Mark, over to you.
Okay, thank you. So this is a project that I think aligns really well with the theme A and theme B. So it's aligning research with patient priorities, and it's incorporating patient and public values into the research process. So just to introduce myself and the team who put this application together. So I'm a health economist at UBC's Faculty of Pharmaceutical Sciences. I've got a scientist appointment at Chaos. And I'm co-leading with Tracy Lee Labber, who's an expert in the kind of methods we're using in this study. She's a visiting fellow from the University of Sydney. So she brings expertise and also some international reach for the results of this project as well. Other members of the team are Nick Bansback, who you'll know from the support unit, Magda Aguiar, who's a trainee on the project. She's going to be joining as a research fellow later this summer. And then we've got two collaborators from McGill. So the first is Brett Toombs, who runs a large scleroderma cohort, and I'll show you the importance of that later. And then also a clinical expert in scleroderma, Marie Hudson, and you'll see the importance of that later as well. And then critically, we've got a knowledge user member, Tiasha Birch, who's the Secretary of Scleroderma BC. And she'll be part of the research team as a knowledge user member as well. And we're going to do further consultations with Scleroderma BC and the Arthritis Patient Advisory Board too as we go through the project. So can I just move on to the next slide? So the project is motivated by the fact that there's a frequent misalignment of healthcare with patient preferences, and that's been shown or been described as leading to key sources of clinical waste. And in summary, I think it's things we worry about patients using too much of things that perhaps won't lead to benefit and using too little of things that could lead to benefit. And we explored this issue in a context of prevention of rheumatoid arthritis. And what got our attention there is there was a lot of focus on studying treatments that are quite aggressive, but were targeted at people who are at high risk of developing rheumatoid arthritis. We asked ourselves questions, are people really going to be willing to take these treatments to prevent rheumatoid arthritis when we're really not that good at predicting who might get the disease, and we're not sure how well these treatments are going to prevent the disease anyway. And what we found was when we did some hypothetical studies, we found the answer was largely no. So we only find strong support that 1 of 5 ongoing trials of preventative treatments for RA actually align with the preferences of people who might be asked to take them. And so we only think that there's strong evidence that 1 of these treatments will be taken up by people. And this kind of posed the question to us, are we wasting research dollars, and are we sort of exploiting people in the wrong way to sort of give them treatments that there wouldn't be any value from? And is there a way that we can incorporate patient preferences more into the design of research? And one of the things we sort of focused on was the fact that companies like Apple wouldn't send a phone to market without understanding what their consumers value. They wouldn't do that without knowing what the potential uptake or market share was of a product. So why don't we do the same? Why don't we use these methods to embed patient priorities in the research process in healthcare? Next slide, please. So the objectives of the proposal that we put forward were to identify a real-life case study of some new intervention that's being planned, and then use methods to help people who might be looking to design studies in this area to generate a more patient-oriented research design. And the process will involve identifying what the key features of a decision might be to take a particular intervention or treatment, prioritize those features to give us a clue what the primary outcomes or what the range of outcomes we should be measuring might be, see what might be potentially acceptable interventions to study in the first place, and then if we go down the line of studying these, how much benefit do these interventions or treatments have to show for them to be acceptable to patients. Next slide, please. So the case study we identified was stem cell transplants in people who have severe scleroderma. So this is the context of people who typically have a very restricted expected lifetime. So their life expectancy is pretty short, so typically about 5 to 7 years. But in these people recently, they've been looking at a way of resetting the immune system, and then people actually generally see an increased event-free and overall survival, and a reduction in the morbidity from disease. So there's a huge potential benefit from this study, but it comes at a cost, and there's a number of different costs here. So there's the toxicity of dampening down someone's immune system through chemotherapy ahead of the treatment or the surgery. There's not an insignificant risk of dying through the surgery that's provides the stem cell transplants. And then there's a bunch of other different factors which are trade-offs as well. So where do you have the treatment? So do you have it in a centre that's local to you, where perhaps there isn't an expert in scleroderma transplants, or do you travel and spend an extended period of time at an expert centre? And then issues with eligibility. These have been, eligibility criteria have been played around with quite a lot in early studies. So there's really not a clear target population for this treatment yet. And shifting those eligibility criteria will affect the risks and benefits from treatment as well. So all these factors play into making it quite a complex area, and an area that's ripe for future studies. Next slide, please. So the methods we're going to employ in exploring this as a case study are first qualitative methods, which will help us work out what are the key features that people who might be expected to make these decisions will be looking to find information on, and what's the main priority of those. And to do that, we'll be using a nominal group technique method, and that's generally a 4-stage focus group approach. So it involves generating ideas, so we can start from a complete blank sheet and just find out from the patient perspective what are the most important factors that might happen in this decision. So participants in the focus group will be given time to consider the context, the treatment, the decisions they might be able to ask, and come up with things that might be of importance to them. There's then a round-robin process of going around the room and capturing all of these different factors that people consider. So once you see an idea on the board, that's kind of listed for later discussion, and we keep going until people have exhausted all the features that they think are important. There's then a process where we allow discussion of these attributes. What do they mean? What does it involve? What information is needed? And those kind of things. And then the final stage is voting to prioritise the importance of the outcomes or the factors that have been identified. So at this stage, we have qualitative information that represent the prioritised outcomes of a group, and I think this is publishable in its own right, but the reason we go through that process primarily is to get to the next stage, which would be a choice-based experiment like a discrete choice experiment. So it's recommended that you start with qualitative input on this type of survey so that you capture the key elements that patients think are important in the decision-making process. And in the choice experiment, we ask people to make hypothetical decisions around different treatments, and that helps us to reveal the importance of different key features that have been identified, and that might tap into our estimate of what should be the primary outcomes if we're doing a trial in this area. We can understand trade-offs that people might make between different features. So, for example, if they're going to accept an increased risk of something happening, how big does the benefit have to be to overcome that risk that they're experiencing or they're expecting to accept? And you can look at different configurations of services and see how much the benefit might need to be for a particular treatment to be acceptable to patients. So we can go to a final step where we predict for any configuration that we can describe using the features that we have, what's the likely acceptability and uptake in practice of that particular service or treatment. We'll recruit people for this through the SPIN cohort, which is run by Brett Toombs, who I mentioned earlier. So he's got a sample of 2,000 patients who regularly complete online surveys from around the world. It's primarily from Canada, the United Kingdom and France. And we'll plan to supplement that using the partnerships that we've created with Scleroderma BC to get a strong flavour of BC perspectives in this result as well. So they've got 200 active patients in their group. They're a very engaged group and very keen to get on with this research as well. So that's where I'll leave it. That's the methods and how they kind of tie to the outcomes we want. And I guess if there's any questions now, I'm happy to take them, or if any come later.
Thank you, Mark. Thank you for the summary of Project 1. Pass over to Stephanie Harvard to give a description of Project 2.
Okay, thank you so much, David. Very happy to be here and for the chance to tell everyone a little bit about this project. So I'll be leading this in partnership with Diego Silva, who's an ethicist working in the Faculty of Health Sciences at SSU, as well as Greg Worker, who is a specialist in modeling and works at the Sutter School of Business. We're also going to be following the support unit process for engaging patient partners. So the title of this study is Value-Based Decisions in Health Economics and Simulation Modeling Studies, and it corresponds to theme H, which is patient and public values in research. So I just want to take a second to look at the concept of values, because we know that values is a term that's used in a lot of different ways, both in real life, in conversation, as well as in the academic disciplines. So when we talk to psychologists or economists, they make different assumptions about values, and as a result, they define values in a very different way. And in this project, we're working with health economists, but we're not actually defining values in the way that health economists are used to defining values, because our project is very much informed by the philosophy of science, and there's a strong ethical aspect to our project. And so we use the term values in this context in a way that philosophers use that term. So we'll just take a second to look at a couple of ways. Oh, and I bounced it back. Pardon me. Okay, thanks. So I'll just take a second to look at a couple of ways that philosophers of science talk about values. So, for example, Kevin Elliott uses a very simple definition and talks about values being something desirable or worthy of pursuit. And Hugh Lacey adds on to that values act as criteria to choose what is good among possible courses of action. And both of those ideas come out in a definition that's used by Daniel Steele, who actually works at UBC. So Steele talks about values are decision vectors that are favorably regarded in a community. So in the context of our project, we're talking about values as something that health economists and modelers regard as being good and that help them to make decisions when they're designing studies and doing their research. Another concept that's important to note in philosophy is that there's a distinction that is often made, a rough distinction, between the things that scientists value in making decisions in the research context and other values, so things like social and ethical values. And in conversation, we have more of a habit of referring to those values just as values. And we can maintain that sort of terminology that we're used to and make a rough distinction between scientific criteria on the one hand, and then values that we're used to understanding in terms of their social and ethical aspects. And that's where we would put patient values in the context of patient-oriented research. So one of the benefits of being able to make that rough distinction in types of values is that we can see what's behind a concept that's been talked about for many decades, which is the value-free ideal for science. And what that ideal has held is that when scientists are doing their work in the internal phases of science, so at the core of scientific reasoning, there's this notion that scientists should not rely on anything but scientific criteria. So they should not be incorporating other values. And that's traditionally been regarded as something that will help preserve objectivity. So as much as that notion has been around for a long time, it's now disputed by a lot of philosophers. And I think I'm going to make the same mistake as before. Oh, there we go. So philosophers increasingly agree that many or most decisions in science actually cannot be made on the basis of scientific criteria alone. And if we had a bit more time today, we could look at the formal challenges that have been made against the value-free ideal. But since we don't have a ton of time today, let's just look at 3 examples where we can see how this idea is intuitive. So For example, when scientists are studying concepts like gender or education, or really anything where there's an idea that the best way to look at the data would be in a categorical sense, scientists can't get around having to decide how many categories to collapse that concept into, and then they have to decide what to call each category. So we can see how values are relevant here to the decision because it's related to what is considered to be important to study and what is considered to be appropriate in terms of how to describe them. Another common example refers to setting thresholds for statistical significance. So very often in science, we use statistical evidence, and we have to decide on a standard of evidence. So that means the standard that needs to be reached before we make a conclusion one way or the other. And one common way to think of this is in weighing and trading off the risk of a type 1 or type 2 error, or what they call false positive or false negative. And we can see how values are relevant to this decision because the risk of a false positive or false negative often depends on the consequences or the context. And in this area, it's clear that patient values are very much relevant to the decision. In a last example, we'll just look at something in the modeling context specifically. And it's intuitive to modelers, people who are familiar with looking at models, that there's a lot of flexibility in terms of how simple or how complex to make the model. And values are relevant to this decision in the sense that one has to consider how important is it for the model to be easy to use, but also what is important to represent in the model? What do we have to include and what can be omitted? So these are all examples of decisions where we can imagine that values are very much relevant. It's because of examples like these, as well as the formal challenges to the value-free ideal, that nowadays it's more common to see philosophers focusing their work on how can we identify value-based decisions in science and characterize them and understand them better? And also, how can we help scientists manage these decisions, typically in partnership with stakeholders, including patients? So in some areas, work in this area is a bit more advanced. So in the modeling world, for example, there's been a lot of progress in climate change modeling. And this is understandable because we can understand that in climate change, what is counted as a climate change impact is very much a value-based decision, as well as decisions around how long into the future are we intending to model the impacts of climate change. So as much as some advances have been made in other areas of modeling, today we don't have a lot of information or a lot of understanding about value-based decisions in health economics modeling specifically. So that brings us to the objectives of this study. So what we're wanting to do with this study is to identify, describe, and characterize value-based decisions that have taken place in recent health economics and simulation modeling studies here in our local context. So the purpose of this is to help researchers here recognize value-based decisions in their studies that are going to arise and to know when and how and why to seek patient input on these choices. We also hope that this project is going to contribute to helping patients remain engaged throughout the entire research process from start to finish. As well, we want to be able to help researchers give patients a genuine and meaningful opportunity to influence research decision-making. So in order to reach these goals, what we're thinking to do is interview health economists and simulation modelers directly. We're going to start by developing an interview tool. And for this, we're going to rely on participant feedback, as well as the literature in philosophy on value-based decisions generally, and focusing as much as we can on the work that's come out of modeling specifically. So the purpose of the interview tool will be to define the concept and to establish the topic for conversation, as well as to have some prompts so that researchers are invited to think about different value-based decisions that come out throughout the entire research process. To recruit experts to participate in these interviews, we're going to go through our local health economics group, which is called HESM. We're basically going to send out an email that describes the study and its purpose, and we'll invite researchers to come and talk to us for about an hour. Interviews will be tape recorded and they'll be transcribed so that we end up with a qualitative data set. And then this will allow us to conduct thematic analysis. And through this process, we'll look at the terms and concepts, the ways that researchers are talking about value-based decisions, and we'll group those ideas into themes. And this will be our first step in helping to understand more about these decisions, where they take place, what they're like, and to characterize them. and hopefully inform some future stages of research with this information. So these are the methods that we've proposed to date, and they are under review. We'll also be working with patient partners, and so we're remaining very much open to feedback on these methods. So that's the update that I have for you today, but I'm available by email at any point for questions that come up. Thank you.
Thank you, Stephanie. Two very comprehensive summaries there of two of the projects that are part of phase one, the HESM funding. I'm going to talk to you a little bit about project 3. So project 3, the title is examining the utility of educational videos for increasing knowledge and enhancing experiences of patient partners in health economics research. So this fits with these communicating results, the communication theme of the methods cluster. And this project really came together through a lot of discussion between all the methods cluster leads, not just the health economics one. And this ended up being a cross-cluster project. So all cluster leads will be part of the research team for this particular project. And it will be led by myself and Nick. And similar to Stephanie's description of how knowledge user members will be identified, we're going to go through the approaches in accordance with the VC support unit policies. So the idea behind this project is that, so by definition, patient-oriented research is done in partnership with patients. And this means that one of our top priorities of the methods cluster is to try and ensure that patient partners participate in our research initiatives, but probably more importantly, that we want to ensure that patient partners have that interest. They want to take part in these health economic studies. It may not necessarily be have that initial level of interest that you may have, a patient partner may have in a different type of health research, and we want to try and overcome that to some extent. And in order to have a meaningful conversation between the patient partner and the researcher, there's obviously some knowledge gap between that. And that will be the same regardless of any research project. And the purpose of this project is to really try and understand different strategies to try and overcome or address that imbalance in knowledge. And in some ways, we're looking to use that to enhance the experience that patient partners have in their engagement with health economics projects. And the reason we think this is important, increasingly we're seeing that decision-making bodies are incorporating, including members of the public and patients in committees to make decisions about allocation of healthcare resources. And some educational materials to enhance an individual's ability to take part in those conversations will be important. Similarly, different research funders may require patient partners to have a very active role in the development of research. And again, any material that we can produce that is evidence-based that can help to improve the conversations and improve the engagement that patient partners have in that process will be of great value. And I mentioned the issue of sustainability on this slide, mainly because we're certainly not viewing this as a sort of case-by-case, study-by-study basis. We really wanted to have material that will be accessible for members of the public and patients to enable them to take part in all kinds of research projects or have an increased level of knowledge about key issues that are going on in either their own access issues with healthcare or more population-level interest in how health economics plays a part in helping understand how we make decisions. And this last point on this slide talks about a longer-term goal. So this is a longer-term cross-cluster goal to have a comprehensive suite of materials available for anybody to access. So what we are planning to do in this project is look at 3 different forms of educational material. So educational videos have been are becoming a very popular way of providing information to those people who are interested, but there are different ways of providing these videos. So whiteboard animation and green screen are 2 possibilities. A whiteboard animation, the idea behind this would be there would be a script on a health economics topic, and that topic will be chosen in combination with, in collaboration with the patient partners on the project. So that script would be read over a video that provides a whiteboard animation that presents the specific details and visual cues, to the script in a fun and engaging approach. Similarly, the green screen video, a talking head style video, so there'll be a health economist on screen, again talking about a particular script on a health economics topic. And then the idea with the green screen video is that the background can be manipulated to provide these visual cues to enhance the information that's being provided in the script. And then we're also pursuing the idea of a short documentary style video on a health economics topic that is looking to engage potentially a different audience. So there's been some evidence and some suggestions that these different approaches to educational materials they differ in their level of success about the type of audience that you're looking to access. And then in talking about this project with other cluster leads and colleagues at the support unit, the idea was that instead of just providing material and making it available, we want to really have a good understanding about whether this is sort of evidence-based and really helping people and meeting the objectives that we want to. Is it increasing motivation to take part in research? Is it increasing people's level of knowledge? And so to do this, how the project will be designed is that there will be a before and after style sort of questioning. So there will be a series of questions that people will be asked, and then they will have access to the educational material, and then be asked questions after the event as well. The co-development of those guiding questions that will go with the material will be developed with the research team and the patient partners. And then we will sort of randomly sample participants in the project. So the example here is around about 1,000 participants will be identified through a market research panel, and we would ask them these guiding questions before they view them at education and material, and then ask them questions again afterwards. And then really trying to tease into these issues of knowledge and the motivation to participate. Something that I also wanted to highlight as part of the work that the Methods Cluster is doing regards to sort of community building initiatives. Now, much of this over the previous 6 or 7 years is very much focused on the local health economics community in Vancouver, which is typically sort of UBC and SFU. But the Methods Cluster and the work of the support unit clearly has a very provincial focus, and we feel that it's our responsibility with regard to health economics to reflect that in the initiatives that we have. So the idea is to rebrand our local events and make material and these events more accessible to people outside of the Lower Mainland. So we do have an annual health economics conference that is typically in May, June each year. And through the health economics and simulation modeling methods cluster, there will be funding for travel bursaries for people outside of the Lower Mainland to come along and be part of that day and present their work and discuss their health economics work with other people in the community. So on a similar note, we've also introduced, we started this in 2018, the academic community half days. So the plan is to host 5 events per year. So in addition to the annual meeting, this means that roughly every 2 months there will be an event that brings together people interested in health economics and simulation modeling. And we've held 2 of these events already. The third is to be held next week. And the organization and the control over these events gets spread about across different research centers in the city. And they typically focus on different themes. So the theme of our first event was on patient engagement in decision making. Our second event was very much focused on genomics. And next week is focusing on the more sort of simulation modeling side of the work of the cluster. And again, once we hear back about the external review of the work plan and the funds become available, there will also be travel bursaries for people outside of the Lower Mainland to attend these events as well. And then finally, I just wanted to mention that included in the work plan of the cluster is website development. It's been something that we've talked about in the health economics community for quite a few years now, and we can use the methods cluster as really providing that impetus to move forward with having a website where people can access information about health economists in the province and the work that they do, and also a great resource to find out about ongoing research studies, training opportunities, patient partner opportunities. And it can also be a place where we can house the educational materials that get developed. In terms of next steps, the immediate next step is to launch the project. So in July and August, the 3 projects that have been explained today will begin. And at the same time, Nick and I are also already in conversation with a number of people about developing project proposals for round 2. And really, what we're talking about here with the different rounds of projects, it was our intention to fund as many projects as possible and bring in as many health economies and simulation modelers across the province as possible. So rather than focusing on a relatively small number of very big projects, our intention is more to try and identify the specific methods questions that can be addressed within those themes that were just on the slide earlier, and get these projects funded and engage as many academics as possible. So we are, as I mentioned, we're already talking to around 6 or 7 potential new projects for round 2, and hopefully they will get launched in the fall towards the end of 2018. So if you do have any questions about the methods cluster in general, rather than specific questions for the projects today, then feel free to contact either of the co-leads or myself or Nick Bansback directly. Alison Hoons is also a contact that's available for any methods cluster activity, not just any methods cluster questions, not just the health economics methods cluster. So at this point, I think I'll hand back over to Pat, and we'll see if we have any questions about today's content.
Thanks, David. Excellent presentation. Thank you so much, all 3 of you, for your presentations today. I know I feel better illuminated, and I'm sure my colleagues in this room do as well. If you have questions for our panel of 3, I ask that you either use the chat function, which is, it looks like a little dialogue, or a cartoon dialogue balloon in the top right-hand area of your screen, or to use your voice the old-fashioned way. You can unmute yourself and pose your question that way. It's entirely up to you. Are there any questions from either those who are participating virtually or in this room?
People unmuted? Have we unmuted people?
I have not, because I'm concerned about background noise. If you'd like to unmute yourself, just hover over your video display and you'll see an option there to unmute yourself. Any questions at all from those participating virtually via WebEx? Sterling, any questions or comments about today's presentation, or?
Thanks very much. It was some great presentation. So I think that's really helpful, and to give people that sense. Is it worth just giving a taste of some of the other themes that are likely to be going forward as part of phase 2? Just to sort of give people a sense of what what the supplementary pieces might be covering, David?
We can do it. It's a little bit early to talk specifically about projects. In terms of phase 2, how things are at the moment is people have indicated that the general area that they are interested in and seeking confirmation that could fit within the remit of the methods cluster. When it comes to the themes, if we could possibly just get the themes back on the screen. There we go. We have no particular focus. We have no intention to target any themes in particular. It will be a matter of what questions come up from those people who are interested. I think given the nature of a lot of the work that people do in the province, so a lot of BC health economists, I think theme C will inevitably be quite popular, looking at patient and public values and research. The educational materials, for example, is about communication, and we also wanted to be quite clear that it doesn't have to be specific to a particular theme. So there were a number of projects that we've spoken to people that could sort of cross different themes in their area. So that is certainly fine from the perspective of me and Nick. Some are quite specific, but things like medication reimbursement, and then we have some the broader themes such as the supply of healthcare. As I mentioned earlier, this is to make sure that regardless of the type of work that that particular academic does, that they see a fit here. The last thing that we wanted was to alienate any researchers who would potentially be eligible for the funding. So I do think it will be that the patient and public values may well dominate. We are very keen to pursue theme B, so looking at diversity and underserved populations. And as we've written up in our work plan and in our conversations with project leads, then we certainly want, regardless of the research question, we want the leads to be thinking about aspects of diversity within those projects. So there are certain things that we want to be sort of consistent across all the projects that get funded.
And if someone does have an idea that fits within one of these themes that they want to begin to explore, then I mean, they're not too late. Like there are opportunities for exploring projects at this point.
Certainly, the possibilities. This should be thought of in terms of a very sort of fluid system. I mean, we had a date last week where people could indicate their initial interest in the second phase of projects, but this isn't a firm deadline. All that really happens is that somebody can contact myself or Nick or go through Alison with just a couple of bullet points to indicate that the area that they're thinking of, and all that will do is trigger that initial conversation with me and Nick. So that could happen. That could happen this week or next week or whenever with regard to phase 2. We're not working on a very rigid timeline. So anybody that is interested, and it's likely there will be a third phase as well, depending on how things come together. But yeah, this is a very fluid process, and all that initial email does is just give cause for that first conversation with me and Nick.
Great. Well, thank you. I'll just ask one more time if there are any questions, although I suspect not. And I see none. I just want to let those of you listening to the recording or in real time, the voice you heard that you do not recognize is that of Sterling Bryan, our scientific director here at the BC Support Unit, just so you know who that was. Are there any closing comments or thoughts from anyone? Hearing none then, I'd like to thank everyone for your time today, those who tuned in, and to our 3 presenters, Stephanie, Mark, and David. Thank you so much for your time putting this together. I know that it takes time to put together a presentation like this, and we appreciate you taking the time out to keep us all informed, and I'm hopeful that this means that there will be some uptake from those in the province of British Columbia to get involved. So thank you all very much, and I wish everyone a very pleasant weekend for those who are listening in real time. Bye now. Thank you so much.
Thanks.
Thank you.